Hello, everybody that is trickling in. This is the PhenoTips Speaker Series. It is our 36th installment, which feels like a lot at this point. We've been doing this almost 6 years now. So very exciting to have quite the panel today. I'm your host, Kira Deneen. We're going to be talking about building business cases for genomics, which I know next to nothing about, which means I'm very excited to learn and learn along with everybody because we're going to be looking at the questions that you submit. So feel free to use the Q&A box if you are watching us live. If you're listening to us later as a podcast, email in questions. But yeah, so for people that are watching live, definitely submit your questions in the Q&A box and we will get to as many as we possibly can. Don't wait until the end to submit your questions because you might forget. So as you think of them, just put them in there. I'll try to remind you throughout the webinar. And as I mentioned, we have such an awesome panel lined up for everybody today. We're going to be asking some questions to get the conversation flowing and again, going to your questions as well. For those that may not be familiar, PhenoTips is a complete EHR integrated solution for medical genetics. Many of us, probably all of us, have experienced that EHRs are not designed with genetics in mind. It's usually an add-on. You've got to upload the pedigree somewhere and it's buried in the media tab, something like that. So it's really helpful that PhenoTips have developed this software and services that ease our workflow as genetic professionals and improve efficiency, which we all need. PhenoTips Genomic Health Record includes tools like inclusive pedigree builders, automated pedigrees, human phenotype ontology capture, built-in cancer risk assessment, diagnostic insights, so many aspects there. So really recommend people to check it out, especially if you are a student. Check it out because you want to check out multiple types of pedigree builders and kind of see what you end up liking once you graduate and you're officially seeing patients all the time. So as I mentioned, I'm Kira Deneen. I'm your host for this webinar. I'm also a certified genetic counselor and science podcaster. I run Gene Pool Media, which is a science podcast network. It includes shows like this one, PhenoTips Speaker Series, as well as DNA Today, a show I've been doing about 14 years. And very similar to the conversation we're going to have today. So enough about me. I would love each of our panelists to introduce themselves. I want to hand it over to Megan first because we work at BayPath together. She is our program director at the Genetic Counseling Program. So Megan, if you could introduce yourself.
Yeah, absolutely. Welcome, everyone. I'm Megan Trinkle-Knotts. As Kira said, I'm the program director for the genetic counseling training program at BayPath. However, before coming here, I have started two clinical practices. One required a business case pitch and all the things that we're going to talk about to our local hospital to be able to start a primarily cancer clinic when I started the new genetic counseling training program at Indiana State University about 10 years ago. And then most recently, I actually started a private practice as well. So I didn't have to pitch to anyone but myself. But so I've worked in clinical practice now for about 20 years and higher education training for about 10.
Andrea, I will kick it over to you next.
Thanks, Kira. Pleasure to be here, and thanks again for the invitation. My name is Andrea Spencer. I'm a partner here at Optimus SBR, and I come from with a bit of a different background to be able to contribute to the discussion. So, just a bit of history. I kind of personally, I actually started in a clinical space, but in the field of speech pathology, and I worked with adults with brain injury for a few years, and then I went to the dark side, did my MBA, and came into consulting, and have been consulting within the healthcare space across Canada for the last 14 years or so. I
Yes,
run a
you're bringing in the Canadian aspect that I know PhenoTips really loves because PhenoTips is Toronto-based.
Yeah, and we are too. So we work across the country, and but we're very familiar with systems around the world because that really informs the work that we do. And we do a ton of work around enabling healthcare organizations, governments, providers to be able to bring their innovations to life, get them funded, make sure that they're embedded effectively into programming. So. Happy to share more about what we do, but that's a little bit about us to kick us off.
Lovely. And Colleen, coming back to PhenoTips, if you could reintroduce yourself to the audience.
Thank you, Kira, and thank you for the invitation to return to PhenoTips and this series. My name is Colleen Campbell, and I am the Director of Genetic Counseling Operations at the University of Iowa Hospitals and Clinics, and where we now have a team of 27 genetic counselors based on a business case. I'm also a past president of NSGC, serving in that role in 2024. Happy to be here today.
Yeah, amazing. Well, as I said, everybody, all-star panel here. And I'm going to start with the most basic question that is probably on some people's minds that are like, okay, I'm hearing this term business case. What is a business case? And the purpose and the context of genetics departments, especially, I'm thinking of that genetic counseling angle as well. Does anyone want to start us out of just that simple definition? Megan.
Happy to jump off. Basically, you are creating something to justify and explain what it is that you're trying to create, how it's going to be successful, how it's going to be funded, in hopes of getting your clinic off the ground, or really whatever it may be. But in this case, I know we're focusing on more of a genomics clinic. So it's that written document, usually comes along with a verbal pitch that goes along with it as well, where you have to kind of do a little bit of an elevator pitch to the higher ups at a hospital system, administration, whomever the powers of be who make decisions would be, is who you're going to be presenting this information to.
Andrea, yeah, something to add on?
Yeah, no, everything that Megan says resonates with me too. I think it's telling the story in a way that in a way that's really going to resonate with the audience that has the power to be able to support. And so there sometimes it can look very different, but they usually have some really common ingredients. I think we're going to get into some of those, but yeah, it's what is the value that what you are offering? What is that going to be to the patient, to the organization, to the system, and making sure that you're telling a compelling evidence-based story to be able to do that. And passion is a great part of it, and passion can come through, but it's not usually enough to get you funded. So making sure you've got the rest of the ingredients as part of that would be really critical to doing a good business case.
I would just add two things. For those of you who are researchers, it's not that dissimilar from a grant proposal, but it's the business version of a grant proposal is the way I sometimes think about it. The other thing, Megan mentioned that there's usually a pitch that goes along with it, and that pitch is typically very short. At least your first pitch may only be like 5 to 10 minutes. So you want to be very high level, very succinct. And the same with your business case. It's going to be very succinct as well.
That's surprising because I was thinking if you're creating this business case and then presenting it, I'm thinking like, oh, this is a detailed hour presentation. That is not the case. So as Colleen was saying, it's like 5, 10 minutes, like, elevator pitch plus, I guess, because it's a little bit longer. Megan, weigh in a little bit more here.
Well, I kind of like to think of it, if you've worked in a clinical space where you've had to present to a physician as they're walking into the clinic room and you spent 40 minutes with that patient and you have to sum it down to a 30-second blurb that you have to spit everything out before they walk in. It's a little bit like that. Now that's a little exaggerated. You obviously have more than 30 seconds, but you have to have that brief little high-level summary down. So a lot of the business cases will start with an executive summary where you get one page, and you're trying to capture everything. And then you have the more detailed, all the pieces that we'll talk about later, kind of thereafter.
Yeah, to be able to really pitch obviously that's in the name, but to say, hey, this is like the bottom line. This is why it's worth it, is what I'm imagining. And I'm getting nods for people that are listening. So yeah, to be like, hey, here's like the ROI, the return on investment. Like here's why we should be doing this. And I'm thinking it's mostly from a financial perspective rather than this is the impact we can have on these people's lives. And as important as that is, that's probably not what to focus on in a business case. Andrea, am I along the right track here?
Yes and no, I would say, Kira. I think in healthcare, we are a people-oriented business. This is everything that we're doing is for people, and the people who are in buying positions are oriented to people, even though they're often, accountable to things like financial ROI and return on investment, and being able to make sure that it is feasible within a tight fiscal environment. We know there's not extra money laying around. But when at least in the Canadian market, and I think this is probably true across the board, whenever I've been in front of leadership and talking about these pieces, or even I've also been on the evaluation side of we're looking at a really balanced way to be able to evaluate what it is. So there are some probably kind of panel number two could be going into a different type of kind of evaluation processes and looking at quality of life indicators. And there's a whole kind of field around economic analysis to be able to understand kind of qualitative benefits of these different types of interventions. But there are also more basic qualitative ways to be able to talk about it. So outcomes and experience, and those are not always expressed through kind of financial means. Finance it matters, but in my experience, leaders are very much valuing kind of a balanced perspective. They want to know, first, feasibility in terms of cost is critical. However, is it going to benefit the patients in a meaningful way? And there's a framework called the quintuple aim, which is kind of that international healthcare improvement framework that's very well adopted, that talks about kind of five main elements around value for money, health equity, patient experience, patient outcomes, provider experience and outcomes. And decision makers are often using a framework like that to be able to make decisions around it, in addition to aligning it with strategic plan and other things that are going on. But there's a lot of factors that would go into those types of decisions that are not just financial. So it's very important to not just focus on those pieces.
I'm so glad I was wrong because that's so much better that we can actually say, hey, here's the impact on human lives and families and patients. So that's a great thing to be wrong about. I love it. And I think, we've had each of you tease like what your experience is just, within genetics, but then with this. But I would like to dive a little bit deeper in with each of you of your experience. Colleen, we could start with you of just what your experience has been in building business cases, because you had teased that, is it 27 genetic counselors that
Yeah.
are into the department? So that is a huge department from my perspective. I worked at a private practice and I was the only genetic counselor. So any department feels big. But tell me about how that came to be, saying, hey, we have whatever number of genetic counselors you started with, and how that business case and the pitch, what was helpful in that to say, hey, now we have a department of 27, and how that kind of came about.
Yeah, happy to share that. So it wasn't that I initially set out to do a business case. I actually got stopped in the hall by our vice president of health affairs at the time. He wanted a graduate program. There were only 5 certified genetic counselors in the state. And so I just kind of laughed and walked away, got called to his office, and then went in with the data and thinking about who are their competitors, if I went in with data from like Stanford or Harvard, that wouldn't matter. So I went in with the data from other Big Ten institutions, so like organizations where they're used to comparing themselves, and let the data kind of speak for itself. And after a couple of those conversations, he said, well, write a business proposal as to how we would solve this, like at the time, shortage. I think he thought I'd probably just go away because I wouldn't know what to do. And I got really lucky that I had a friend getting their MBA, and I was like, I know how to write a grant, but I don't know how to write a business proposal. And they kind of outlined the pieces for me, and then, started working on that. I will say it was about a year before I was ready. I did a lot of like due diligence and talking to people about the ways to set up and grow genetic counseling like services, just from around the country and just trying to learn from other people's experiences. Also institutionally, it's one thing if I were to do this, but our the strength of our program is we're really embedded throughout the whole health system. And so having the head of the cancer center advocate, the head of OBGYN advocate, the head of neurology, where we were all aligned in our messaging, and they could echo the same things that I was planning on presenting to the leadership team was really helpful. Obviously, making sure the 5 genetic counselors' voices were incorporated in that vision and as well was really important. So really like talking to others, having them pick apart the idea that I was developing and really criticize it so that I could make it more, a stronger case when I went to the leadership. So that's how it really came about. And now, that's probably the biggest, largest budget business case I ever created. But now I feel like there's a lot of other business cases that come up and they might be smaller, either budget or impact, but it's a skill that comes up pretty frequently in my role today.
Yeah, that's impressive and a good point of bringing in other departments to say this would help us
Mhm.
because, I've Colleen in this show and another show, like we've talked about like billing codes and that aspect
Yeah.
and how helpful it is of saying, okay, if we can have this session and it leads to someone going to seek and make appointments in oncology, look at all the revenue that is the downstream effect
Mhm.
is I've learned directly from you and Brian Ray's that that's really helpful to be able to capture that part. Is that part of what the business case was as well? Of like, this is how people will have more appointments and maybe they'll have preventative surgeries because of this and those aspects?
Yeah, I would say so. The original business case I did was 10 years ago, and I wasn't as well versed in like downstream revenues. I was pretty green at the time. But there was that. The other piece that was really important to the university at the time was they were trying to recruit physicians in oncology, cardiology, and neurology. And so they actually had lost some physician recruits when they didn't have a genetic counselor in oncology. And they also hired people who said, well, we're coming in from wherever and we're used to having 3 genetic counselors. And so I need, as part of my startup package, 3 genetic counselors. And so working with those people on not only the clinical side, but also the faculty recruitment side, because I'm at a university. So having those physicians who are going to come in and generate clinical revenue as well as research grants and other things was really helpful. So that
Yeah, that's
it was
amazing.
a little of all of those things.
Yeah.
And then
And
also,
Meg, go ahead,
just
Colleen.
real
Yeah.
quick, the other thing is just flat out competition. I mean, universities, hospitals are competing all the time for, which sounds strange, but it is a business and they're trying to compete for those services. And so realizing where they might lose patients to other hospital systems, and how to, there's a little bit of like keeping up with the Joneses that is real. And so how do we do that and how do we make sure we're competitive is important too.
Yeah. Certainly at the university level and even others. If it's a smaller practice, something like that, they're still competing with the practice down the street. So that kind of applies to, I would think, every level. Megan, is your experience similar to Colleen's? Is there areas where you're like, well, this was where my experience was different?
Yeah, I'd say somewhat similar on a slightly smaller scale, but I think, Colleen touching on the getting champions was really helpful to be able to say, this is what we can offer you and your physicians and get their buy-in was important. If I had just come and said, you should start a genetic service, that's probably not going to go anywhere. But if I can come in and say, we think you should start this genetic service and look at the value it adds to oncology and OBGYN and all these different groups. And you have those physicians to say, yes, look at what it will do for me. That was a big, important piece. So I wholeheartedly agree with taking that time to talk with the providers at the facility you're considering pitching to, but then also the other genetic counselors and the other groups and, get a feel, how do you want this clinic to run? And the best way that you can do that is really talking with other people. So I wholeheartedly agree with kind of taking that time to really talk with others around and figure out what's the best way to do it. I will say I'm glad the idea of the competitive nature came up, partially because we got a ton of pushback at this downstream revenue. I came prepared with all the data from UT Southwest that has some really great data on downstream revenue, particularly in a cancer setting, and shows that, this genetic counselor had this millions of dollars of downstream revenue. And my facility said, great, we don't care about that. They have to make their own money. What else you got? And it was like, ooh. Wow. Okay. That was like my big selling point was all of this downstream revenue. And so the two things that really helped, I guess maybe three things that really I was able to lean in after they said, we don't want to hear about downstream revenue. One of them was, well, what about the hospital down the street? Your patients are having to travel to be able to get these genetic services, and then they're staying in that facility because they are now, that's where they got their diagnosis, and so that's where they're going to do their management. And so it was kind of downstream revenue, but it was a different angle because it was about keeping those patients in-house and how can we keep them in-house and, get their care that way. So that was really helpful to kind of take that downstream and kind of angle it a little bit differently, sort of the keeping up with the Joneses idea, as well as they were looking to expand some of their accreditations as a hospital. And so to be able to be an accredited breast center, they had to have access to genetic services. To be able to have a certain level of NICU, you have to have access to genetic services. And so that was a helpful way of tapping things that this can help the hospital build their recognition by meeting some of those standards. So that was a helpful approach as well. And then, as we hinted at before, they really did care about patient outcomes. And so they really did want to see this is how many people we could potentially prevent cancer down the road. These are the number of people in a cascade setting that could come in and have preventative care and then have increased patient satisfaction and then therefore refer to your facility because they had increased satisfaction. And, so those were some angles that were really helpful for us in terms of getting that buy-in. So that was a slightly similar approach, but a slightly, different angle to it that we found to be really useful. The final was one we've already touched on a little bit as well of what can I take off your plate? And so genetics from a physician perspective is, a semester of training, and then you're kind of on your own to figure it out. And so if I can step in and prevent unnecessary testing, possible interpretation errors, you don't have to order it. Let me do it for you. I'll handle the letters of medical necessity and the insurance authorizations, and let us tackle all of that and the interpretation and all of those things. And you can handle the things that you're an expert in, which would be, managing someone's diagnosis. And so that was really helpful too, to really be concrete about what I could take off some other providers' plate to be able to offer that service.
So a lot of these are really kind of top level, like how does this help the whole healthcare system that we're talking
Mhm.
about, the organization, whatever level that is. And both Colleen and Megan, you're US based. So let's get the Canadian perspective in here of how that's different because Canada has a very different healthcare system. So Andrea, educate us on your perspective.
Yeah, you know what? We have a lot of differences in the way that our systems work. However, in this case, people are predictable and unpredictable creatures, and the processes are generally the same. And so maybe I'd offer like a bit of and we make business decisions in the same way too, right? And so as I think about maybe just a different way to offer in terms of a way to structure and think about this. A business plan is actually kind of a tangible tactical output of a change management process. Change management is this like really interesting field that we spend a ton of time on, and kind of the consulting and business side of healthcare, where it's where you really all of the elements that we've just talked about really fit into a nice position. And so if you think about a change management framework, we'll use one called ProSci right now. There is something that where you start with building awareness. And so when we talk about all of the different folks that need to be aware of what the what problem we're trying to solve. What is the thing that is there? What is the data that supports this need for a business case? Building the awareness of different people is a really big part of setting the stage to be able to even bring your ask ahead. And both Colleen and Megan, we spoke about some of the different types of stakeholders that you might want to include. So it's going to be some of your administrators and the people who hold the purse strings, your CFO, your whoever. There's your clinical VPs, whoever are in those seats. But it's also going to be the physician group and the clinician group and all of the other people. And so when you move down this change management framework to the next stage, which is around building desire, this is where you use the old acronym WIFM, what's in it for me? So making sure that all of your different stakeholders are understanding truly, what can I take off your plate? How is this going to make sense? Making it seem like it's their idea to be able to invest in genomics is, especially with the physician crowd. I don't know if there's any physicians in the audience, but it's a really interesting group, and they love to use data to be able to tell a great story. If there's no data, it doesn't exist. And so being able to bring people along using different means, depending on how people need to understand that information and build a want to be able to move something forward. Then the knowledge and ability part of a change framework are really about making sure that people have the tools, the training, all of the different ingredients to be able to make the change successful. And so your business plan can also, when it talks about here's how it's going to work, and here are the implementation steps, and here's how it's going to translate from an idea into a reality, being able to articulate that. And Megan, your experience of being able to say, oh my goodness, here's my plan. This is my logical plan. This is my case. This is the plan A. Having plan B and C handy is always a very, very important part. But also, unpacking plan A, B, and C a little bit further to be able to increase the probability of success. So if we think that, A is the way to go, what are doing the mental activity to be able to step back and say, there's no guarantee that I'm going to get the volumes. There's no guarantee, people are going to walk across the street to do X, Y, Z, whatever the model is. But what are the ways that I can make sure that there's higher probability that those outcomes will happen? Do we engage marketing? Do we engage different means to be able to do this? So you work that kind of information into your change process, get the buy-in from all of the different folks that would need to be involved, and have them part of your story. And then you have multiple voices all around that are talking about the critical need for investing in this solution. And then the final part of the model is around sustainability and reinforcement, and how do you make sure that you're evaluating and reporting on the work and making sure that you're getting what you need, even if you have to pilot or start small. Canada, by the way, is a land of pilots. So sometimes you have to get a little bit to be able to demonstrate value and then expand. It's shifting a little bit, but it's something that we're dealing with regularly. Anyways, I thought I'd offer a bit of a framework to be able to think about it, because it can be helpful to be able to think about what content needs to go in there that your funders are going to want to be thinking through.
Yeah, to be able to check off the box and be like, okay, what are the steps and the content that needs to be in there? And Andrea, you had mentioned the C-suite level. So talking about all the chiefs, chief financial officer, chief medical officer. So when people are putting together a business case and this proposal, doing that maybe first pitch, and maybe there's that follow-up presentation, what are some questions that they should be prepared to answer from the CFO, the CMO? Are there ones that you've been asked or you prepped ahead of time because you knew, oh, they might go here?
Yeah, really good question. So, and it kind of ties to some of the barriers that my colleagues have shared as well. Maybe I'll just preface first by saying they're probably not your first conversation. Depending what position you're in, you're going to want to do, to my change management point, you're going to want to be able to engage different people at different levels, and they should know what you're going to talk about before you even walk into the room and know what you're going to pitch. It shouldn't be a surprise, because that kind of the buy-in and the work and the being able to bring the idea forward through different voices would be a tip that I would share for people to think about. first of all, it'll be very tricky to get a meeting if there's no heads up around, here's what I want to pitch. But at the same time, you want there to be some general excitement and buy-in about like, here's what it is, and now let's make it tangible. But when you do get into that room, as I think Megan and Colleen, you both mentioned, you aren't likely to have a ton of time. They're likely thinking about 100,000 other things that are on their plates. You will not know what those other things are, and you are not likely to be the only person pitching even that day. And so the competition is real, not just between different facilities, but it's also real between different, because there's finite dollars. And within any hospital system, there's only a certain amount of money to go around. So their questions are going to be, why should it, and whether they say it explicitly this way or not, but it's, why should I pick your initiative versus all of these other high value things that I think make really good sense too. Being able to understand too, kind of like what bucket of funding or like what budget line stuff comes out of can also be very helpful to be thinking about it. Is there an innovation line? Is it a clinical programming line? Is there specific funding that is kind of earmarked for this kind of work? And like understanding some of that can be a helpful tool to help you think about where to go. But to your question of, what questions should they be prepared to ask? It's, how is this going to make our patients better? How is this going to make our providers more efficient? How is it going to drive outcomes and make our business, our hospital business, work better? So really on some of those outcomes pieces, it's going to be, what do I have to put in, not just in terms of finance, but in terms of the effort required to make it happen. Do they have to reallocate, a project manager, data people, like anybody else to be able to do this? Because what we're talking about is not just a program that's going to operate in a vacuum. It's going to have implications across the center. We've just talked about a whole bunch of different departments. So being able to articulate, here's what I specifically need, not just from the financials, to be able to go. I'm sure my colleagues have others. I've been adding a lot here.
Yeah. Colleen, you want to add on?
I would add, in the US, they're also going to ask about that revenue piece possibly. And like Megan said, downstream revenue is not as appealing as immediate revenue. And so thinking about that, how did other places fund a similar initiative? Those sometimes you might get pushback. Well, we're not fill in the blank named institution. So being prepared for those, and then that competition piece, I think, is also where it can come in. I also think you should be prepared that, like Andrea said, they're hearing a lot of pitches. They might be like totally poker face. You will not get a response that day, right? And it's just the start of the conversation if you're lucky. I think, like Andrea said, they're hearing hundreds of pitches, and I view it kind of as a funnel. And if you're persistent and you are diligent and you address their concerns, you kind of make it to the next level. And I think a lot of people hear like the criticisms and concerns and just kind of give up, which is fine. And sometimes you might too, and that's telling to you, right? Like, how much are you willing to put in to do the extra legwork to go see find the answers to their questions or address their critiques? Will tell you how much you want to move forward with this, and then also help you kind of, that persistence piece, I think, does show them that, like, yeah, you're willing to do this. It's important enough, not only to you, but you feel it's important to the institution to keep pushing forward. So
yeah, have to be adamant about it. Just keep doing it.
Yeah,
Megan.
I also want to add, don't forget that these individuals may have no idea what genetic counseling is. And so you do have to have a little bit of background of just, who are we as genetic counselors and what do we do for patients, right? Like, what even is it? In addition to how it fits into that larger hospital system and genomics. And so I think not to forget that you have to have a little bit of that background as well.
Yeah, that's a very good point, because I think at this point, I've explained what a genetic counselor is how many times, right, in different places. So just being able to have your elevator pitch there of, here's the background information. This is what genetic counselors are actually doing. And probably a lot of it, not assuming that they know certain aspects of being able to provide that background and definition. And we talked about, in Colleen, you were saying how it's kind of this funnel and that you got to keep being persistent with it. What is a realistic timeline from starting a business case to getting a decision from hospital leadership? Because from what you mentioned earlier, you had been working on the business case for a long time because it was like you were new to it. But once you actually submitted it, how did that process go? I'm sure it's very different at different institutions.
Yeah, I'm just looking. I have my like original one right here beside me. So I was originally asked in December 2013 to start the graduate program. I submitted the business case October 2014, and then by June 2015, we were starting to hire people within it. So it was, after that submission, then there were the multiple conversations that we're talking about with different
Mhm.
C-suite leaders along the way. And it wasn't all at once. Similar to Andrea, I think let's do a little piece of this, let's do a little bit more. It was, like an $8 million proposal. So how do we kind of gradually step into it? And then once that went okay, then it was probably another year before like it was all approved and off to the races.
Yeah, that's helpful to have that sense of just like, it's not going to be weeks, probably not months. You're looking more like a year for you, kind of year and a half of by the time you like started to actually, getting the program up and running.
I would also add, I don't know, Megan and Andrea, your thoughts on this, but timing matters, just like everything else in life. And so there have been times where we've wanted to pursue something, but there was a leadership change or budget cuts or something like that. And so it wasn't the right time to pitch the idea. And so working on the business case and generating everything. So when it was the right time and there was another incident and a problem that arose within the institution, you're like, well, here's the solution, and you have it ready to go. I think timing is really critical for these. I don't know what your thoughts are on that, but that was
Yeah,
the
Megan, do you want to weigh in?
Yeah, not necessarily on the timing piece. I was just going to echo, we were a much, much, much smaller pitch, and it still was a, multi-year process. So, definitely a slow all the steps. Just all of it is not very fast. And so we actually started with just a slight difference. And I also was starting a training program. So that's funny that yours was very similar. So I was already hired to start the program. That was ball rolling. I didn't have to do anything with that. The clinic was separate. And so that was fortunate for me because obviously I had plenty of other things. But we were able to offer a 1 year, like, no cost to you kind of trial to the hospital and said, listen, we will donate basically my time for 1 day a week if you can find a way to donate space. And so they donated basically a like one room office. And we said, let's just trial it for a year. Now, it took almost a year to get that trial up and running, but then we trialed it for a year. And then I was able to come back and say, here's the data. Here's how many patients we saw. Here's how many positive results. Here's how many came back and did screening. Here's our patient satisfaction. We were able to get this level of satisfaction. And so then we were able to really do like what I would think of as our bigger pitch of now you need to hire someone and make this a full-time clinic. And here's how it can grow. And, here's the education opportunities that we offered to your staff during this first year to really show that value. So it was a different approach. We didn't come in with here's an $8 million pitch. And it still was a multi-year process to get that going before it was a standalone clinic.
And Andrea, that's kind of what you mentioned earlier, like pilots. Like that sounds like a pilot in that sense.
Yeah, maybe a practical example. I actually had a call this morning with with a hospital leader who's got a really exciting program that to your point, Megan, around kind of creative funding and creative negotiation to be able to say, we've got people that are interested in it. The initiative that this leader was talking about it was about a program, it wasn't a genetics program, but it was around, it was something that they actually had convinced their hospital foundation to fund for a year. And then they were able to bring patients in, deliver the service that they had committed to, but actually were able to to show value for money by stretching that initial year of funding across 2 years. So they were able to, and now, my conversation was about let's develop an economic analysis to be able to prove the value for money and look at all the things we talked about earlier. But so that's kind of where they're at. So it's been a 2 year process for them, plus some pitch time in advance to their foundation. So not a lot of differences here. Maybe the only other piece I would add to it is that in terms of timing, to your original question, timing absolutely matters, as Colleen said. One of the things that I always ask when I'm working with somebody on this is, when does budget go in? When are they having? When is leadership having their deliberations? In Ontario, we're in a kind of an interesting hospital deficit situation right now. That's a little bit more significant than in previous years, and so a lot of reluctance to spend on anything that's not deemed critical. And so, but there are times in the year when they get closer to our end of fiscal, which is end of March, where they've got a much clearer picture of will there be surplus or deficit in any particular areas. And then they're like, okay, well, we've got 2 months to make this decision on what we want to use any potential surplus for, and you want to be ready, as Megan said, with that opportunity, if at all possible, to be able to hit that timing. So that's important to know. And then I also similarly keeping an eye on other funding mechanisms. Again, in Canadian market, we do a lot of grants. We do a lot of like one time or like kind of time-based contracting. So you might do 3 years to deliver particular outcomes, and here's some funding. You must submit your application for this in this very structured way within the next 2 months or the next even 4 weeks sometimes, which is crazy when you want something that's very data driven. So having that information handy can be super critical.
Yeah, start collecting it now if it's something that you're thinking about in the future, because then you have that to go back to.
Right when
And we're
it's
getting
hot.
a lot.
Yeah.
Yeah, yeah. And Megan, did you want to chime in?
I was just going to say we actually had great success at reaching our hospital foundation as well. So that was our how we ended up getting our foot in the door to make it. In addition, like we did our little pilot for the first year, and then we approached the foundation. They said they would help fund a certain amount to then, really get it up and rolling. And so if your facility has some kind of a foundation, really looking at what is their mission, what is their goal and what they fund, can you meet that? And so, we were a very rural area. And so we had a way of being able to help offer through the foundation, transportation support for patients if they were to come. And, so that was a great way to sort of get an in as well by tapping into that foundation to meet their needs too.
Yeah, yeah. This is just such great advice you're all providing so far. We have quite a few questions coming in, so I'm gonna start going through these. So if you are watching live, be sure to use the Q&A box to submit your question that you have. And we don't say names, I just say initials so you know I'm talking about you, but because this is public, just in case. So SR wants to know, she says, or they say that I know we touched on it in different ways, but can we talk and give a little more information on how you provide the revenue generation? Although GCs bill for their day of time, we are currently getting pushback because of other things that support our team are not revenue generating. So would love additional insights on how to define revenue to the powers that be. So any advice on that, Colleen?
I mean, I would start off by clarifying from their perspective what they're looking for, right? You could spin your wheels trying to generate something, but they might have a very specific thing in mind. And so learning what that is and then kind of revisiting the question to see that. Sometimes revenue, I'm reading the question and other things that support the team that are not revenue generating. So that might be like a genetic counseling assistant or some kind of software, but how those allow the genetic counselors to see more patients, which then could generate possibly more revenue. What's going to generate more revenue, though, is how a physician can see more patients because they're going to bill at a higher rate than a genetic counselor would. And the genetic counselor reimbursement is still highly variable across the country, at least in the US.
Yes. Yeah, we can link to that we'll be posting this and we'll link to more information about that. Megan.
Yeah, I would say we tapped on the literal revenue, right? The reimbursement for our code, because again, they had no idea that that was even a possibility. And so we really wanted to encourage that, yes, you absolutely can bill for your time. Now, there's state differences too in, does Medicaid reimburse 96041? So there are differences in how well that is reimbursed. But then we also, as I kind of touched on earlier, we hinted at the time back to the physician. And so that was a helpful way of it wasn't direct revenue, but if I can get this much time back so that your physician who can bill at a higher rate has more time to do XYZ, that was a way of not touching downstream revenue, not touching direct revenue, but it still had a revenue component to it. And so that was helpful as well to make sure to include that angle with things.
Andrea.
Yeah, I mean, my colleagues are the experts on this, but maybe just offer that taking a look at some of the different indicators that your hospital leadership looks at can often be a good signal as to what they're looking at in terms of revenue generation and how they capture it as well. So, for example, in Canada, we often look at kind of cost avoidance, for example. So, in a particular scenario, if you implement program X, then somebody is not likely to spend as much time in an expensive emergency department bed and need different care. So being able to, it's a different way to measure, but it can be another way to be able to demonstrate the value of a particular initiative.
And we touched on that as well in terms of cancer prevention, right? Cascade testing, we can get screening done. That's downstream revenue. That's separate, but also the cancer prevention. And so that was exactly what you just talked about, where we were able to say, here are the dollars saved, the healthcare dollars saved by identifying this person at risk, getting them screening early, doing XYZ. And so that was another kind of what you were just describing, but a specific one that we used in a cancer clinic.
And then I would also add for us, it was that faculty recruitment aspect as well, where by having a genetic counselor, they would be more attractive to oncology recruits, cardiology recruits, neurology recruits. And so those providers and researchers as well it's not direct like revenue, but that was something that was very important to the institution at that time.
Yeah, definitely. And we have another question from MD. I don't know or they are a PhD. It's kind of funny, like their initials are MD, but they have a PhD. So they are a PhD geneticist with experience in architecting 20-year longitudinal family-based studies, and they've seen the challenge of standardizing 17,000 plus records using ICD-10 or ICD-11. So their question is, how do we best present the long-term clinical utility of such standardized databases to hospital stakeholders?
I think this sounds like just thinking about the PhD projects and how large they can be. It's hard, right? Like you're taking 20 years of work and you're trying to get it into something very discrete. I have, and I've found that visual aids can be really, really helpful. And I know like 20 years of longitudinal data, that's going to be really hard to do, but what would be the most impactful to them? So we had some very basic maps. And when they looked at it, it was Iowa stood out in the sea of, others. So working with marketing was really helpful there. Now I work directly with professionals who do mapping on a regular basis, and it's much more sophisticated and way more impactful. But using those visuals that make it very clear, so they could look at it and without any knowledge see like, oh, Iowa is behind all of the neighboring states, or we need to do this so that we're no longer, the outlier here. That is really helpful. So I don't know if there's a way to visualize what you're doing and then have that description about that long-term clinical utility to go along with it. But I think the visuals can't be underestimated.
Yeah, those can certainly be powerful way of just conveying so much information at once that's easy to digest in that sense. I mean, there's a reason why genetic counselors use visual aids with patients, right? Just using that in a different format. And this is not a question, but I really wanted to point this out that SB says, just note on the cost saving conversations, PGX or pharmacogenomic testing, genetic testing is huge for that with avoidance of emergency department visits, adverse events. I was at a conference a couple months ago, Precision Medicine World Conference, and that was a big conversation there that just kept coming up of the utility of doing PGX and having that integrated as part of it and patient outcomes. Megan, do you have anything to add on to that?
I just wanted to make sure we clarified PGX, we're talking about pharmacogenomic testing. So
Yes.
doing, that is a specific kind of genetic test, just in case someone wasn't sure what the PGX was.
Yes. Yes. Thank you. Of just having that more integrated into healthcare and, saying we've used oncology as an example kind of throughout, doing pharmacogenomic testing maybe before certain chemotherapy and saying, oh, this is actually not going to work well with this person and can prevent certain really, really catastrophic things. Yeah, Colleen.
I was just going to echo that. I think if you had asked me 15 years ago where pharmacogenomics would be first integrated and who would be demanding it, the ED was not the department that I would have thought of, but they're definitely the ones who ask. And we did a retrospective analysis of admissions from the ED into the inpatient setting in the hospital. And basically, there's one person a day for 3 years that was admitted in the 3 year time frame of the study that was admitted for an adverse drug reaction. And sadly, when we went to try to offer them the pharmacogenomic testing, it most had passed away, so we couldn't actually publish that result. But there were definitely cases where it would have been avoided, the ED visit. So when you're thinking about quality of life, as well as the cost savings of an inpatient admission is huge.
Yeah, and different patient outcomes of like how did that patient do with their treatment? That's important data for, hospitals and these different systems to have. So I think that's really, really important. And SR also is asking a question that I'm going to pitch to Megan here. As the need to prove why genetic clinics and genetic counselors are important and necessary, do we feel that integrating classes that touch on business models would be beneficial for GC schools? Maybe this is something we should be doing at Bay Path, do a little workshop that you lead, Megan.
Ooh,
I don't know.
they do already. So
They do
they are
already. Oh my
required
gosh, the
to
students
write
didn't
a
tell me
business
that last
pitch.
night. Yeah.
So we do, and this is why I had done this, right? I had created a clinic, did a whole pitch. In my first year teaching 10 years ago, I had a graduate and be asked to start a clinic, and they, had no idea where to begin. And I thought, this is wild that they have no idea where to begin, and like we don't do anything on the backside. So I've slowly built over the years. They do have to create a business case to justify a cancer clinic, and so they have to look through, how are they going to bill, how are they going to generate revenue, what outcomes are they going to look for. How are they going to measure success? They have to be able to explain the background. They had to do a little, I think this past year we might not have done the presentation, but they had to do an elevator pitch to justify their components. And I've had multiple students over the years use it successfully to actually begin a new clinic or add a new position. And so it has been something that we've integrated, and it's been, some hate it, of course, but it's also been well received, and I've had a few use it very successfully. So.
Yeah, that's awesome. That's kind of one of those workshops that I feel like a lot of programs should start using. And we've kind of been talking about billing here and there. And Megan, you mentioned that you now have your own private practice. There's someone listening, watching live VR that is looking for some guidance on this billing aspect, which Colleen, I'll probably have you weigh on as well because of your extensive experience with the new billing code. So I'm just going to kind of summarize what they submitted. But they successfully pitched two healthcare organizations without any organic genetic assets. They have both C-suite approval and clinical buy-in, and they're running into roadblocks with this billing. So they have sent NSGC 96041 FAQ and denial documents and have used them to create a how-to step-by-step guide for billing, but they're still being told by the billing department that they can't be reimbursed for genetic counseling only services, which depending on what state you're in, if you don't have licensure, like there's a lot of different issues here. Megan, are there things that you've kind of come across with like private practice of issues, like any similar obstacles?
Yes, I have not been successful in getting much by way of reimbursement from insurance companies, despite spending months of time trying to get credentialed and all of those kinds of things. It's incredibly time consuming. And so most private practices are reliant on self pay, which is
Yeah.
challenging because then you're not utilizing healthcare dollars in a way that you could be utilizing them. There's, all kinds of things there that limits the patients that can come to you. So there's lots of issues there. There's been some talk among the private practice groups. We meet periodically to see if there's a way that we as a group, now that there are a large number of private practices compared to what it would have been, a decade ago, to see if we can collectively have some power to pitch some of these insurance organizations to try and help with that reimbursement side. We haven't, started all of that, but there are talks about how can we, as small individual groups, work together to have a little bit more power and say. I think getting our federal bill through is really, really critical
Yep.
to be able to get that reimbursement. And so, that is a huge roadblock nationally here in the US, just to be recognized as providers. And that's roadblock number one in my mind.
Yeah. And Colleen, any advice from your perspective of someone that helped push this so that we have this new billing code?
Yes. So I would say, this is not unique to billing. I also would add this happens with test ordering as well. So even if you have licensure and you can order tests, if a test is ordered by a genetic counselor for a patient with Medicare, it's not going to be reimbursed. So it extends beyond billing to ordering. And I think, this is where there's a couple things underway. And this is a big aspect of why in the current NSGC strategic plan, when we were building that, we have such an emphasis on billing and reimbursement. And we decided to not only focus on Medicare, which we've been working on achieving that, but to add in Medicaid and those private payers. And we actually totally restructured NSGC's payer relations and have people that are working, have professionals working on all those different aspects. So I would say, there are major policy gaps. We're working on a publication from that board time on a landscape assessment we did and what constitutes a good policy, right? And for Medicaid, there are many, it's amazing how variable Medicaid is for genetic counseling. The CPT code may be on the fee schedule, but they may not recognize genetic counselors. But like in Iowa, for example, they require genetic counseling in order to have genetic testing. So how do you require genetic counseling, but you don't reimburse for genetic counseling provided by genetic counselors, right? So having those discussions is going to be really important. Unfortunately, there's not a quick fix for that, right? But NSGC has now developed a toolkit, and the Access Committee is working actively on both Medicaid reimbursement and recognition, Medicare, and payer, different private payers. And so they're working on toolkits. There's going to be a lot more coming out in the next year. I think that will be resources to help people. There's also a listserv specifically for the new code, and so I think tapping into some of those resources will be helpful. I think what you're describing is not unique just to private practice. It happens even for those of us like in an academic medical center. So it's something where we do need to band together. And one of the things that will help is there are still a lot of genetic counselors who don't bill for their services. And if you're not billing for the services, the payers don't know, it doesn't hit their radar. And so we need to be more consistent in our billing practices and then work together to change those policies. So sorry, there's not a
Yeah.
quick fix. I wish there was. I wish I could say, here's the magic answer, but there's policy gaps across the board, as well as, just consistent billing practices that we need to be working on.
Yeah. And Andrea, would love for you to chime in as we wrap up.
Yeah, I'll be brief. Just to say what you've shared resonates. We our systems are structured differently, but there's some pros and cons to that as well for us. Although we're largely a single payer system funded through our provinces to be able to provide the bulk of care, we've got a number of different kind of private pay systems that kind of augment that. But one of the challenges that we experience is that the fee schedule that our single payer uses, it doesn't always keep up with the innovations and the needs of this particular sector. And so I know it's a challenge that we hear a ton of, and similar advocacy efforts are required.
Yeah. Well, hopefully today's webinar has given everybody some more information from, before you got on today, and to try to provide as much as we can coming from PhenoTips. We're also going to be providing a template that our panelists have all weighed in on and been able to review. So that's going to be shared with you. You're also going to see a feedback link in your browser when this webinar ends, as well as emailed to you within the next day. So please take a minute to offer your feedback, because it directly affects what webinars we're having in the future, what topics, what we're being focused on. And if you want alerts on upcoming sessions, make sure that you are checking out our website, phenotips.com. And if you want to access other installments, we have 35 other installments of the PhenoTips Speaker Series. That's going to be under the Resources tab, and then the Speaker Series on that drop-down menu. And I'm very excited to announce that our next installment is going to be our Pride Edition, which we've been doing for a number of years now. I'm part of the queer community, so it's one of my favorite installments every year, the PhenoTips Speaker Series. And that pretty obviously is going to be in June for Pride Month. So definitely stay tuned for that. Megan, Colleen, Andrea, thank you so much for weighing in on this. I have learned so much, and that I should probably take our students workshop with Megan of how to build a business case, because I think, there's a lot of value in all of this. So thank you all so much. And we hope that everybody has learned as much as I have and has a great rest of their day. Thank you, everybody, for tuning in.
Thank you so much for
Bye.
joining us.